There are changes which are happening in the respiratory system. Okay, so what are the changes which are happening in the respiratory system? Anatomical changes. The diaphragm is elevated by around 4 centimeter, and that leads to the decreased total lung capacity by around 5% and increased diaphragmatic exertion by around 1 to 2 centimeter. So breathing becomes diaphragmatic. Okay, so in pregnancy, the breathing is diaphragmatic. There is a decrease in the total lung capacity by around 5% and increased diaphragmatic excursion around 1 to 2 centimeter. Okay, so there are certain changes which are happening in the thoracic cage. The subcostal angle will be changed to 103 degree from 68 degree to 103 degree. Transverse chest diameter is increased by around 2 centimeter and the chest circumference will be increased by around 5 to 7 centimeter. Okay. Mucosal changes, the nasopharynx will show hyperemia and edema. There will be nasal stuffiness and occasional epistaxis. There are ventilation changes. It is a hyperventilation state. And this is mainly because of the effect of the progesterone on the respiratory center. There is increased carbon dioxide sensitivity. This also you should remember that it is a hyperventilation state, and this is mainly because of the progesterone effect on the respiratory center and increased CO2 sensitivity. What happens to the respiratory rate? There is no change in the respiratory rate. It remains constant. The vital capacity almost remains constant. However, the tidal volume will be raised by the 40%. The residual volume will be reduced by the 20%, and the total lung capacity is reduced by the 40%, 5%. Okay. So respiratory rate, vital capacity will remain same. There are questions which are asked on the capacities also. Okay. So respiratory rate is same around 15. Vital capacity is same. The tidal volume will be increased by around 40% from 475 to 675. Residual volume from 965 to 765. Okay. So RV will be reduced by around 20% and the total lung capacity will be reduced by around 5%. Okay. So what are the all functional effects of this? There is an increase in the tidal volume and increase in the minute ventilation by around 40%. So the tidal volume is also increased and the minute ventilation is also increased. And patient may complain of shortness of the breath, which is a physiological dyspnea. Okay. So there are certain changes which are happening in the acid-base balance. This also you should remember because the questions are asked always. There is one question on the acid-base balance. Okay. So changes due to the hyperventilation. What happens due to the hyperventilation? There is a alkalosis, slight increase in the pH. PaO2 will be raised, but the PaCO2 will be reduced. Okay. So pH will be increased, PaO2 will be increased, while PaCO2 will be reduced. Okay. So PaO2, which is 95 millimeters of mercury in non-pregnant state, will become 106, while PaCO2, which is around 38 millimeters of mercury, will near term will become 32 millimeters of mercury. That will be reduced. pH, which is 7.4, will become around 7.42, slight increase in the pH, and the bicarb level, which is around 26 millimoles per liter, will become 22 millimoles per liter. That is reduced. Okay, so the bicarbs are reduced and it is a respiratory alkalosis state. Okay, so interpretation is a respiratory alkalosis. There is a compensatory increase in the renal excretion of the bicarb. Okay, so this you should remember because this respiratory alkalosis is more frequently asked. Okay. Then what happens to the oxygen consumption? It is increased by around 20 to 40% due to the fetus, placenta, and maternal tissues. There are changes which are happening in the urinary system. The kidney length is increased by around 1 centimeter. Renal plasma flow is increased by around 50 to 75%. The peak is around 16 weeks of gestation. GFR is increased by around 50% throughout the pregnancy. Okay. There are changes biochemical effects which are seen. There is a decrease in serum creatinine, BUN, and the uric acid. What happens to the tubular function? There is incomplete resorption of glucose, amino acid, vitamin that leads to the glycosuria, which is physiological. Okay, so the tubular function, there is an incomplete absorption or reabsorption of the glucose, amino acids, and the vitamins, leading to the glycosuria, which is physiological. There are changes which are happening in the ureter. The ureter will become atonic because of the progesterone effect, dilated above the level of the pelvic ring, which is more marked on the right side. Causes of right side dilatation, because one is the uterine dextrotation and also compression by the right ovarian vein. Apart from that, additional changes such as elongation, kinking, muscle hypertrophy are also seen in the ureter. Okay. What are the changes which are happening in the bladder? There is a congestion and hypertrophy, and there is edema. Okay, urinary symptoms early around 6 to 8 weeks of gestation, there is increased frequency, that is polyuria. Mid pregnancy, generally there is a relief. Late pregnancy, again frequency returns. Okay, patient may have stress incontinence late in the pregnancy. Then what happens in the alimentary system? Oral changes, gums will be congested, spongy, and bleed easily. GI motility will be reduced. There is a reduction in the tone and the motility under the progesterone effect. Esophagus and stomach, cardiac sphincter is relaxed. That is why there is an acid reflux. Gastric emptying is delayed. That is why there is a feeling of fullness. Then gastric secretion is reduced. That reduces the ulcer risk. There are intestinal changes such as decreased peristalsis leading to the constipation, increased absorption of the nutrients. In liver and gallbladder, liver, there is no structural change. Mild functional depression is there. Okay. Then liver function tests such as bilirubin, AST, ALT, CPK, LDH, all will remain normal, while only alkaline phosphatase will be increased. Gallbladder becomes atonic because of the progesterone effect, and there is a mild cholestasis because of the estrogen. Clinically, you get an increased gallstones. Okay. In the nervous system, there are certain psychological changes such as emotional stability, irritability, sleeplessness, nausea, vomiting, and postpartum disorders such as blues, depression, psychosis. They are common, especially the patients who are susceptible. Okay. Then nerve compression syndromes. Important one are the carpal tunnel syndrome, which is mainly because of the medial nerve compression. The patient will complain of pain and paresthesia in the hand. Okay, so carpal tunnel syndrome, mainly because of the medial nerve compression, there is a pain and paresthesia in the hand. While meralgia paras, paresthetica, this is because of the lateral cutaneous nerve compression, and there is a numbness in the thigh. Okay, so these are the two important nerve compression symptoms. One in the upper limb, one in the lower limb. Upper limb, you have carpal tunnel syndrome because of the median nerve compression. Okay, there will be paresthesia in the hand. While there is a lateral cutaneous nerve compression leading to the thigh numbness, that is condition is called as meralgia paresthetica. Okay. Then changes in the calcium and locomotor system. Calcium metabolism, total fetal requirement is around 28 gram. 80% needed in last trimester. Daily requirement is around 1 to 1.5 gram per day. Biochemical changes such as total calcium will be reduced. Ionized calcium will remain normal, and phosphate will also remain normal. Then what are the hormonal changes? There is an increased vitamin D, 125 dihydroxy cholecalciferol. There is increase in the calcitonin by around increased 20%, and that protects the bones. Absorption, increase intestinal and renal calcium absorption. Musculoskeletal changes, ligament will become soft and increase joint mobility. Clinically, patient will complain of backache, waddling gait, increased lumbar lordosis, etc. So just to revise, respiratory system, there is a hyperventilation and respiratory alkalosis. Urinary system, there is increased GFR and glycosuria. GIT, there is a decreased motility and the constipation. In the liver, there is a mild dysfunction. Nervous system will show emotional changes. Calcium, there is increased demand and the bone protection. Okay. So in pregnancy, hyperventilation is seen. That leads to the respiratory alkalosis. Kidney function is increased, and there is a decreased creatinine and increased GFR. Okay. Progesterone will lead to the decreased GI motility and decreased ureteral tone. Then calcium demand is increased. Last trimester is very critical for this, and many symptoms such as dyspnea, constipation, frequency are physiological. Okay, so we have finished the topic of physiological changes in pregnancy. Thank you. We have few questions. Doctor, both of you read half up.
Yes, sir.
Okay, Dr. Sansi, you start. You cover 7, 8 questions, then Dr. Monica will cover. Yeah.
Yes, sir. A 28-year-old priming gravida at 10 weeks presents with bluish discoloration of vaginal mucosa. What is this sign called? Sir, option D, Jacomer sign.
Yes. So bluish discoloration is the Jack-Weimer sign. Okay. Bluish discoloration of the vaginal mucosa is the Jack-Weimer sign due to increased vascularity. Chadwick sign is cervix and vagina, often used interchangeably, but Jack-Weimer's is more specific. Okay. Next.
Which of the following is the main reason for physiological anemia in pregnancy? Reduced RBC production, iron deficiency, increased plasma volume, increased hemolysis, decreased erythropoietin. Sir, option C, increased plasma volume.
Plasma volume is increased. Ideally, there should be disproportionate increase should be the more ideal answer. Okay, increase plasma volume. Plasma volume is increased more than the RBC, leading to the hemodilution. RBC mass also increases. Okay, but disproportionate increase. Next.
A pregnant woman has HB of 10 gram per deciliter at term with no symptoms. What is most likely explanation? 10 gram per deciliter at term with no symptoms. What is the most likely explanation? Pathological anemia, iron deficiency anemia, hemodilution, hemolysis, bone marrow suppression. Sir, option C, hemodilution.
Yes, hemodilution. Okay. So HB falls by around 2 gram per deciliter physiologically due to disproportionate plasma expansion. Next.
Which clotting factor is significantly increased during pregnancy? Which clotting factor is significantly increased during pregnancy? Factor 11, factor 13, no, it is decreased. Factor 1, fibrinogen, factor 12, factor 2. Sir, option E, factor 2. Factor 1, no, factor 1.
Factor 1, fibrinogen is increased by around 50%. Okay, pregnancy is a hypercoagulable state. Next.
A woman at 32 weeks gestation develops sudden hypotension when lying syndrome. What is when lying supine? What is the cause? Aortic compression, IVC compression, reduced cardiac output, reduce SBR, reduce venous return, increase venous return. Sir, option B, IVC compression.
At 32 weeks, sudden hypotension when lying supine position. So there is an IVC compression. So supine hypotension syndrome, gravid uterus compresses on IVC, leading to decreased venous return. Okay, next.
Cardiac output in pregnancy increases mainly due to increased heart rate, increased stroke volume only, increased stroke volume and heart rate, reduced afterload only, increased preload only. Sir, option C, increased stroke volume
Yes,
and heart rate.
both are increased, stroke volume and heart rate. That will lead to increased cardiac output. Okay, so both contribute to 40 to 50% rise in cardiac output. Next.
Which of the following best explains decreased diastolic BP in pregnancy? Reduced cardiac output, increased blood viscosity, decreased SVR, increased aldosterone, reduced plasma volume. Sir, option C, decreased SVR.
Yes, systemic vascular resistance is reduced. So under the influence of progesterone, there is a vasodilatation. So SVR is reduced. Next.
A pregnant woman has glycosuria but normal blood glucose. What is the explanation? Diabetes mellitus, increased insulin resistance, increased GFR, reduced tubular secretion, increased gluconeogenesis. Sir, option C, increased GFR.
Yes, GFR is increased. So filtered glucose exceeds tubular reabsorption threshold. Okay, continue if you then yeah.
Which respiratory change is most characteristic of pregnancy? Increased respiratory rate, decreased tidal volume, increased tidal volume, decreased minute ventilation, increased residual volume. Sir, option C, increased tidal volume.
Most characteristic of tidal volume.
Respiratory rate actually also increases, but increased
Respiratory
tidal
rate is
volume.
also increased. No, respiratory rate remains unchanged. Okay.
Okay.
Tidal volume
Yes,
increases.
yes, yes.
Yes, tidal
Ah,
volume is increases. Okay. There is increase in the tidal volume and increase in the minute ventilation. Dr. Monica, you want to continue?
Yes, sir.
Yeah.
Pregnancy is associated with which acid-base change? A. Metabolic acidosis. B. Respiratory acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. And E. No change. Sir, answer is C. Respiratory alkalosis.
Yes, respiratory alkalosis, hyperventilation reduces PaCO2 and that leads to the alkalosis. Next.
Which hormone is primarily responsible for insulin resistance in pregnancy? A. Oxytocin. B. HCG. C. HPL. D. Prolactin. And E. Relaxin. Sir, C. HPL.
Yes, HPL. Okay. So HPL is a major anti-insulin hormone. Next.
Which metabolic state best describe pregnancy? A. Catabolic state. B. Ketogenic state. C. Anabolic and diabetogenic state. D. Hypoglycemic state only. E. Lipolytic state only. Sir, C. Anabolic and diabetogenic state.
Yes. So it is an anabolic and diabetogenic state. So there is a protein building plus insulin resistance. Next.
Which of the following is a physiological change in liver function test? A. Increase bilirubin. B. Increase AST. C. Increase ALT. D. Increase alkaline phosphate. E. Increase albumin. Sir, answer is D. Increase alkaline phosphatase.
Yes. Alkaline phosphatase levels are increased during pregnancy. It is a placental origin. Continue the next.
A pregnant woman complains of heartburn. Which of the following is a main cause? A. Increased gastric acid. B. Increased mortality. C. Relaxed cardiac sphincter. D. Delayed gastric emptying only. C. Increased peristalsis. Sir, answer is C. Relaxed cardiac sphincter or D.
It should be
Gastric emptying.
it should be relaxed cardiac sphincter. Okay, progesterone causes lower esophageal sphincter relaxation, leading to the reflux. Next.
Which renal change occurs in pregnancy? A. Decreased GFR. B. Increased creatinine. C. Increased BUN. D. Increased renal plasma flow. E. Reduced kidney size. So answer is D. Increased renal plasma flow.
Correct, correct. So increase renal plasma flow and GFR, that and there is a decrease in serum creatinine and BUN. Next.
Which of the following contributes most to edema in pregnancy? A. Increase albumin. B. Increase oncotic pressure. C. Decrease oncotic pressure. D. Reduce venous pressure. E. Reduce blood volume. Sir, answer is C. Reduce oncotic
Yes,
pressure.
oncotic pressure will be reduced and hydrostatic pressure is increased. Okay, so these things, both the things are actually acting together. But here, with respect to the proteins and all, there is a decrease of oncotic pressure because albumin is reduced, plus increased venous pressure, as I mentioned, that leads to the edema. Next.
Which is the main reason for increased uterine blood flow at term? A. Increased cardiac output only. B. Vasoconstriction. D. Vasodilatation by hormone. D. Increased blood viscosity. And E. Reduce resistance in systemic circulation. Sir, increased cardiac output only.
Main
Not
reason for increased uterine blood flow, which is 75 ml, will become 750 ml. Okay, so vasodilatation by hormones and actually multiple factors are responsible.
Resistance is also there, na? So systemic
Yeah,
vascular resistance. Then increased cardiac output will be there and vasodilatation will be there.
yeah. B is wrong. D is also wrong. Okay, and E is also correct. You reduce resistance in the systemic cell, that is also correct. And there is a vasodilation. So actually it is the effect of A plus C plus E. Okay, but main reason what they have given is a vasodilatation by hormones. Okay, progesterone, nitrous oxide, prostaglandin. Next.
Which hematological changes reduces blood viscosity? A. Increase RBC mass. B. Increase fibrinogen. C. Hemodilution. D. Leukocytosis. E. Increase platelets. Sir, C. Hemodilution.
Correct. Hemodilution, plasma increase more than the RBC, leading to decreased viscosity. Continue. Next.
Which of the following is a true about iron metabolism in pregnancy? Iron requirement decreases. Total requirement is 500 milligram. Most requirement is in first trimester. Total requirement 1000 mg. And fetal iron depends on maternal HB. Study total requirement is 1000 milligram.
Correct. Correct. Total is around 1000 milligram. Majority is needed in the third trimester. Fetus protected even if mother is deficient. Okay. Next.
Pregnant woman develops tingling in her hand due to median nerve compression. What is this condition? A. Sciatica, B. Myalgia, paresthesia, C. Carpal tunnel syndrome, D. Peripheral neuropathy, E. Radiculopathy. So carpal tunnel syndrome.
Yes, upper limb carpal tunnel syndrome, lower limb myalgia paresthetica, and it is a which nerve in the lateral cutaneous nerve of the thigh. Okay, here carpal tunnel syndrome is because of the median nerve compression at wrist, okay, which is common in pregnancy. So the take-home message is that pregnancy is a high volume, low resistance state. Hemodilution leads to the physiological anemia. Hypercoagulable state leads to the risk of thrombosis. Respiratory alkalosis is normal. Insulin resistance leads to the diabetogenic state. GFR is increased. That is why glycosuria is common. Supine hypertension leads to the IVC, is mainly because of this IVC compression. Okay, so that finishes our topic of physiological changes in pregnancy. Thank you.